Hello everyone, I'm Dokter Kim from Korea. Today we gonna see together the LiveSurgery manipulate administrated from the Dentium company. Today's topic is immediate implant placement with simultaneous bridge augmentation. The different thing from the transmucosal approach, I applied the vestibular incision and the flapless implant placement. So first I placed the implant without any flap elevation. Once I placed the implant, I opened the flap through the vestibular incision and applied the bone graft through the vestibular incision. This is something special for today's LiveSurgery. Okay, so let's review the patient information. 63-year female patient present to the clinic with a chief complaint of fixed partial denture dislodgement, and as a past dental history, she has the implant surgery and implant restoration on posterior teeth already, and as a present illness, the secondary caries and chronic inflammation on the anterior tooth area, and periodontal bone loss on the 32 to 42. This is a panoramic radiograph and periapical radiograph. If you see the periapical radiograph, you can see the restoration was fallen out, and remaining teeth has some secondary caries, so we decide to extract all the remaining dentition on the lower anterior tooth area. So as a clinical exam, if you see on the right hand side, there is the previous restoration, but at the time when we placed the implant, the restoration was already fallen out, dislodged. So today's plan is extracting the remaining dentition on the anterior tooth area and placing implant immediately, and applying the bone graft through the vestibular incision. So this is a surgery plan. So number 32, 42, immediate implant placement after tooth extraction, and horizontal augmentation on the 32, 42. We're gonna use the tent board for the maintaining space, and also we're gonna use the OSTEON Xeno Collagen for the bone graft material. It's very convenient for manipulating. It's collagenated bone graft, and also we're gonna apply the Collagen Graft as a barrier membrane. It could be a controversial anyway, but in Korea, in my practice, recently I applied the Collagen Graft, collagen matrix for the barrier membrane. So for the this specific patient, we applied Xeno Collagen bone graft material and the Collagen Graft, and placed the narrow diameter implant, 3.5 millimeter diameter and 9 millimeter length. So, and simultaneous bone graft is a contouring augmentation. There's two different type of the bright implant. One is tissue level, is very strong, it's convenient. If you see the design, the connection part is a kind of an external connection type, and also outside of the metal wall is thick enough, so it's very strong. It's resist for the fracture. So, and also the thread design is very convenient for the immediate implant placement. However, and also another type of the bright implants, bone level implant, but for this specific patient, we had to control the depth of the implant, because the buccal side there was some kind of there's a lot of chance for the descent defect on anterior tooth area. Therefore, we had to control the depth of the implant. Therefore, we choose the bone level bright implant. The same, a little bit different design in the connection, but very strong, stronger than the other previous implant system. So I choose the narrow diameter implant of a bone level implant. So also I apply the collagen matrix. Collagen Graft X1D is we used to use the Collagen Graft 2. It's the same thing. Collagen Graft 2 is Collagen Graft X1D. Recently, the Dentium Xeno company made two different collagen grafts. So X1D, X2D, X3D. It depends on the density. So 1D is the collagen graft, and 2D is more denser than X1D. X3D is denser than the X2D, X3D. So for the generally, when we apply the collagen matrix for the purpose of the barrier membrane, my preference is collagen graft X1D. So we can use this one also as a barrier membrane, also increasing the thickness of the soft tissue. X2D, I didn't use the X2D for this specific patient, but we can use this one for several different purposes. First is the substitute of the soft tissue graft, and also the socket sealing for the rigid preservation technique. The reason why I prefer this X2D for the rigid preservation technique is very dense. Therefore, we can suture with this material itself. Therefore, it's very convenient for the rigid preservation technique. And also for the socket sealing, it rests longer than the other material because, as I mentioned, this is denser than the previous one. Therefore, it's very good for the rigid preservation and resolve later than the previous one. Therefore, it's convenient for the applying for the rigid preservation technique for the socket sealing. So this is one example. After extraction of the first molar, instead of placing implant immediately, we choose the rigid preservation technique. We apply the bone graft material, OSTEON Xeno Collagen. The collagenated bone is also very good for the socket seal, the rigid preservation technique, because they maintain the contour and also minimizing the particle dissipation. So Xeno Collagen bone graft material was applied and also covered with the remaining granulation tissue is one popular technique nowadays, and also apply the X2D for the rigid preservation for the socket sealing. If you see the healing after 1 week, healed beautifully already, the soft tissue healed beautifully, and the 3 week, so almost healed outside, and wait until 3 months, and we place the implant, and we made the restoration after 4 weeks or 6 weeks. So another technique, it also could be applied for the immediate implant placement, because on the posterior tooth area, when we apply the immediate implant placement technique, there's a huge gap defect and huge soft tissue loss. So therefore, we have to compensate. We have to minimize the particle dissipation. The X2D is very convenient for this situation. We made some hole in the middle of the collagen matrix and connected with the healing abutment and wait the healing. After 2 weeks, there's beautiful healing, and after 1 month, it's almost healed, beautifully healed. The soft tissue was beautifully healed. So it's very convenient using the collagen X2D for the socket sealing technique, or the covering the gap defect after immediate implant placement. So let's go back to the case. So we remove the old restoration and the extractor tooth. Instead of elevator, if possible, I think the using the forceps could be a good choice for the minimizing the trauma after tooth extraction. Maybe it could be fractured like this, but then we can apply the elevator. The important thing is we have to minimize the trauma. Otherwise, during the healing, there will be more bone loss. If you are making the trauma during the extraction procedure, there will be more chance of the dehiscence defect, because the anterior tooth area, lower anterior tooth area, the alveolar ridge is very thin. Therefore, it's not enough space for placing implant. But let's say if there is a huge defect on the buccal side, it could be very difficult for applying the simple implant placement without any bone graft material. Therefore, one of the most important thing is minimize the trauma during the extraction. So I apply. Sometimes we can apply the forceps and the elevator. It's good technique to hold the teeth with the forceps, and instead of twist like this, making movement like this, I always making the rotation force. It's one of the best way for the minimizing the trauma on the extraction socket. So this one, so sometimes we have to apply the elevator. The reason why I placed the other hand, the thumb, left hand thumb on the lingual side to minimize the trauma. Sometimes when you apply the force with the forceps could slip to the lingual side and can make some damage on the mouth floor or tongue. Therefore, I protect the mouth floor and tongues with the other hand. And after luxation safely without any major trauma, I could extract the tooth. But it's fractured because it's root canal treated and post placed on the tooth. There's a lot of chance for the fracture of the tooth during the extraction procedure. So I applied the one size bigger elevator and extracting, luxated enough, and remove the root remnant and evaluating extraction socket. One of the most important things for the immediate placement or ridge preservation is removing the regeneration tissue from the extraction socket. Or sometimes we can use the regeneration tissue for the as a socket sealing or the covering the soft tissue defect. Anyway, the important thing is separating the regeneration tissue from the bone. So fresh bone surface has to be exposed, placing implant, or placing bone graft. Otherwise, we cannot get the good result. So it's important. And another thing is adjacent teeth, root surface could be the reservoir of the biofilm. So the root planning, I'm always spending some maybe around 5 to 10 minutes to remove the biofilm and calculus and the root surface of adjacent incision like this. I apply the Grace curette and the other side, and removing plug and the calculus and root planning. Let's say if there is some remnant of the calculus or the biofilm, even though we applied successfully the implant on the extraction side, the implant, we cannot guarantee the success of the implant. There's a lot of papers supporting that. I made some research 10 years back about placing implant, the adjusted teeth with the inflammation and the biofilm. The failure rate increased, and also the bone contact is significantly lower than the other group. The other group is implant placement. The adjacent teeth, the root surface is clean. So cleaning the root planing and removing the biofilm from the adjacent tooth is very important procedure. So I spend about 5 minutes for the root planing, and now we are ready. If you are confident in the anterior tooth area, you can consider the flat surgery. If you make the surgical template, it will be good. However, sometimes it's difficult to make the surgical template. Then just if you understand the configuration of the remaining ridge and the extraction socket, it's not very difficult to doing the implant placement, the flammness. However, we have to make sure after placing implant, the location of the vertical location of the implant, and also the presence of the dehiscence defect on the buccal side. I'm going to show how we evaluate that one. So even though I place the implant without flap elevation, the reason why my preference is flap surgery, because once we open the flap, we're gonna lose some bone. We're gonna lose some soft tissue. There's a lot of supporting papers about that. So instead of elevating the flap, I'm placing implant. And after the placing implant, I open the flap with the vestibular incision and will make sure inside and the location of the implant, vertical position, and the presence of dehiscence defect. For this case in advance, I'm telling you in advance, we found out some dehiscence defect, so I positioned the implant a little bit deeper, and also still there was some dehiscence defect, and we applied the bone graft material. And for that case, we need some space maintenance, and therefore we applied the tentacle screw for the space maintenance. I'm going to show that case. It's a very difficult anterior tooth area, lower mandible, because there's not many chance for the drilling sequence. Let's say there's 5.0 diameter implant. There are several different steps. Even though we made a different angle and location of the implant at the beginning, there's a lot of chance we can change it. However, in anterior tooth area, especially the lower, there's not more chance. I think the 3 sequences done is no more chance. So first Lindemann drill, second Lindemann drill, and final drill. That's it. There's no chance for the correcting the position of the angulation of the implant. So it's very different. First drilling is very important. So now it's time to evaluating the inside. Once we finish the drilling, I want you to evaluate the inside, how it looks, whether there's the dehiscence defect, or how thin the buccal side of the bone, or after drilling, whether we made some dehiscence defect during the bone site preparation. So this is time for the evaluating. You're gonna see the ones was just only with the vestibular incision. You can see clearly inside of the bone configuration and location of the crestal bone and the presence of a dehiscence defect. See, we found out. I didn't make the dehiscence defect during the drilling sequences. I think these patients already had the dehiscence defect in the buccal side. So now we have to decide. So I decide to placing implant and a little bit deeper. And if you place the implant a little bit deeper than usual, we can probably minimize the defect size of decent defect around the implant, and also evaluating the location of the crest bone on the number 32. Yeah. And also there is maybe 3 millimeter distance defect. To minimize the size of the distance defect around the implant, I place the implant a little bit deeper and apply the bone graft to cover the distance defect simultaneously when we placing implant. So now we are finishing the evaluating the inside, and also so I was thinking we have to do the bone graft to cover the distance defect. That's why I applied the bone screw. It will be used for the tentable, so maintaining the space after augmentation of the bone and membrane. Otherwise, it will be collapsed. Even though we apply the bone graft inside, there is some pressure from the outside, from the flap during the healing. Therefore, the augmented bone and membrane will be collapsed during the healing. That's why I apply the tentable for maintaining the space. Once we position, we just rotate it at the same time and holding the handle with the other side hand, and made sure we have pretty much good stability. Sometimes we can use with handpiece, but I like use the hand instrument because we can change the position and we can make sure the stability of the screw. So I think there's not a recommendation how many tentable we have to make. So if it can support the space, I think it's a tool. Screw is pretty enough for supporting the small size of the distance defect. Okay, so we're gonna apply the bone graft to the space where the two tension screw made. So placing implant, the bone level implant. As I mentioned, the reason why I didn't use the tissue level implant for this specific case, we have to place the implant a little bit deeper than the usual. In that case, I think the bone level implant is the better than tissue level implant. Tissue level implant, the thread design is designed for the immediate implant placement, a little bit aggressive, more aggressive, and the connection is strong, but it's good for the immediate implant placement in the anterior tooth area. However, in the case we have to control the depth. So, we are placing a little bit deeper than usual. For the depth control, I think the bone level implant is better than tissue level implant. That's why I choose the bone level implant for this case. And checking the location of the platform, and also checking the initial stability, and checking the size of the remaining defect on the buccal side. For that case, I think that size is pretty, maybe 3 millimeter of the descent defect was pretty enough to cover the bone made by the two with the 2 tentacles like this. So placing implant and 2 tentacles surround and applying the bone graft and covering the with the collagen matrix is the plan for today. And so we are thinking a little bit different position. No, the other side. Sometimes the reason why I unscrew and screw it again, sometimes there could be the high pressure during the using the torque wrench. Therefore, release the torque a little bit with the reverse side on screen and screwing again. Once we release the high torque of the implant, high pressure to the bone, and we got pretty good initial stability and connect the healing abutment. And exposed implant surface will be covered by the bone graft. So we are evaluating that. Some people say the vestibular incision is not easy. However, for me, it's very good choice, especially for the soft tissue graft. I think I introduced my soft tissue graft technique before. So soft tissue graft and vestibular incision is we are checking the probably positioning the implant a little bit higher. I evaluated so changing the minor change of the implant position vertically. The Vista technique and the Homajade from the California, USC. So it is very famous for the vestibular incision. He applied mostly the soft tissue. However, sometimes he is showing applying the bone graft material with the vestibular incision, the same technique. So my favorite, one of my favorite technique is for the soft tissue graft is vestibular incision. So I'm starting with the soft tissue graft with the vestibular incision. Nowadays I'm applying this vestibular incision for the hard tissue and soft tissue, or sometimes hard tissue and soft tissue together. So once we finished the positioning the implant of the number 42, now it's time for placing another implant for the number 32. Other than the number 42, this side didn't show any kind of descent defect. We didn't apply the bone graft too much on the number 32 side. And checking through the space we made through the vestibular incision and location of the implant, vertical position. I'm showing it's not too much defect on the other side. So therefore, we just change the position a little bit deeper, and that's it. I didn't apply too much bone graft for this case because this defect is not really big. And also evaluating through the extraction socket. And for the remaining extraction socket and 41, 31, we're going to apply the bone graft for the rigid preservation technique, and we're going to use that space for the pontic area. So we are planning making the crown and bridge for the restoration design. When we applied the healing abutment, we found out the buccal-ringle relationship a little bit was changed. So therefore, we are pushing we are changing the direction of the implant a little bit. That's why we disconnect and connect the healing abutment. Okay. Now it's time applying the collagen matrix X1D for the purpose of the barrier membrane. 25 millimeter, 30 millimeter by 30 millimeter, 2.5 centimeter, 3.0 centimeter. The size, we trimmed it to apply the inside of the space we made. When we apply it first, the collagen matrix is a little bit tough, so it's not easy to manipulate. But once it was hydrated through the water, saline for the blood, it will be convenient for manipulating. The reason why we apply the barrier membrane first is always same. So we have to minimize the time for the bone after bone grafting bone. We have to minimize the time until the suture procedure. This is one of the reasons for that is for the minimizing the contamination of the bone graft. Barrier membrane is also important. However, bone graft is more important, making that it has to be replaced by the new bone. Once it is contaminated through the saline or the outside, it's less chance. It will be less chance for the making new bone. So good result. That's why we apply the membrane first always, and apply the bone graft later. So the space we made through the vestibular incision, I applied the collagen matrix first for the barrier membrane, and once it was hydrated, it's becoming more easier for manipulating. So always using the two hand. So left hand stabilize the membrane with the one parasite elevator, and the other side we are changing the location, pushing, and sometimes we draw, and sometimes we have to push. Yeah, so making the ideal position, just like a pouch. So now we are evaluating how much bone we have to apply. Now it's time for the apply the bone graft material. particulated bone is good. Well, sometimes not very easy for the manipulating the particulated bone. So collagenated bone, we just apply the black. OSTEON Xeno Collagen, we just cut it in half piece. So we applied and the manipulating also with the instrument, two instrument, pushing in the inside. We already know the configuration of the defect and the size of the pocket we made, pouch we made, enough space. So we just apply only for the that much. Yeah, that's we're gonna fill that space with the bone graft material. Not too much, of augmentation.
훨씬 좋아. 조작성도 좋아. 너무 달라질까? 써주게? 네. 환자분은 차지하고
If you see the base of the collagen matrix, in absorbing the blood from the bottom, so it's moisturized, hydrated, as becoming the soft. It's more convenient for manipulating. For the other side, we just apply the bone graft itself. It's just contouring augmentation. As I mentioned, there's not too, the distance defect is not really big. So for that case, we just need the contouring augmentation. That's it. So apply the bone graft collagen matrix. Collagen matrix fully reserve the blood, so it's just like a sponge. It's very convenient for manipulating. So we applied the bone graft on both sides. However, this defect size was bigger for the right hand side of patient. That's why we apply bone graft and the tent pole and the collagen matrix. But the other side, the distance defect was not really big. In that case, we just applied the bone graft for the purpose of the contouring augmentation. Contouring augmentation is looks more natural contour, because it has, after we extract the tooth, mostly the contour of the alveolar ridge, we're gonna lose the contour. There will be some resorption of the bone. That's why, for compensating that deficiency, we apply the bone graft sometimes. We apply the collagen matrix sometimes. That's we call this one the contouring augmentation. We are applying probably it's a continuous suture. Continuous suture. After we finish the suture of the vestibular incision area, we're gonna apply the bone graft on the extraction socket for the number 31, 41, and we're gonna cover with the sealing with the collagen matrix, but we're gonna skip it because it's a very simple method. Once we finish the suture on the vestibular incision area like this,
그런 게 되게 많대. 그래서 여러 가지 이제 나이 들어서 젊었을 때 운동을 해야 되는 이유 중에 하나가, 젊었을 때 그런 식으로 신경 전달 패스를 만들어 놓은 사람은 그거는 남아있다.
It's a continuous suture.
파킨슨이 왔어. 너무 신기하더라. 그거는 할 수 있어. 근데 농구공이 없어.
We made the vestibular incision, apply the bone graft the space became bigger. Then some people can think that it will be difficult for the primary closure. However, because we made the vestibular incision in the oral mucosa, not carcinogenic tissue, there's a lot of chance for the primary closure, because we don't have to worry about the tension of the oral mucosa area. Very flexible. So see, we didn't have any problem for the primary closure because we are using oral mucosa for that.
무의식 중에 할 수 있는 그런 행동은 안 된다는 거죠. 중시를 가지고 일부러 신경 써서 하는 것들은 남아있다는 거죠. 제시입니다.
We have to leave some loop because we have to make it tie. Or this would be the last step for this kind of not last one. Once again, so making another loop for the continuous suture, and probably this one would be last. Now we are making tie. So just now, now we have to cut it. Okay, that's it. So we apply the vestibular incision, as now it's the socket rich preservation technique. Vestibular incision, and evaluate the inside, the presence of descent defect or the bone loss around the implant. And once you finished, we expected the necessity for applying the horizontal augmentation. We applied the 2/10 around the future place for the implant placement. Then we implant was placed, and applied the membrane for collagen matrix for the membrane, and applied the bone graft and another bone graft for we placed the implant on the 40 to 32, and applied the only bone graft for the 32 on the bone graft and the membrane for the 42, and finished with the suture and applying the rich preservation technique for the remaining extraction socket. This is all about today's surgical procedure. I'm going to skip it. This one is very simple. Also, the OSTEON Xeno Collagen was applied, and will be covered with the collagen matrix. The orifice of the extraction socket will be covered with the collagen matrix. That's it. Okay, let's stop here. So this is the after surgery. As I mentioned, the implant was placed a little bit deeper, but didn't have any problem for making the restoration. And the two plates was placed parallelly. It's better, yes, convenient for making the restoration without any distortion during the impression technique. And the two tent pole will be removed. The disadvantage of this technique, we have to remove the tent pole, but it's later, maybe 3 months or 4 months. So if you see carefully the vestibule area, maybe most of the time the tent pole will be shown through the thin lining of the soft tissue. It's not very difficult to remove it. Just make the small incision and to remove the tent pole. It's easy. So two implant was placed. For the number 42, we placed the 3.5 diameter, narrow diameter implant, bright bone level implant, the length of the implant 9. And for the 32, same bright bone level implant, 3.5 diameter, and 9 millimeter length. This is after the surgery. As I mentioned, we skipped it, but for the remaining extraction socket, we applied the bone graft and covered with the collagen matrix X1D, and this post-op. Okay, that's it. Before and after. Before the surgery and after the surgery. Okay. Okay, there was a Q&A question about some immediate implant placement. What are your criteria to proceed with or postpone immediate implant placement? It's a very good question. So when do we decide to the immediate implant placement? When we are deciding to postpone the implant placement, most of the time, first choice in Korea, we are choosing the immediate implant placement. When do we have to choose the immediate implant placement? It depends on the defect size. If the defect size, this decent defect size after placing implant, if it is too big, I think it's better for postpone implant later. After probably sometimes we need a staged approach with the bone graft. Then we are placing implant later. It'll be better for making the more aesthetically pleasing implant. The first one is defect size. The second one is the primary stability, for especially the anterior tooth area. So for the getting the primary stability is very important. If we cannot get enough primary stability after placing implant, it will be better to postpone the implant placement later. And also, third thing is the inflammation. If there's too much inflammation in the extraction socket, we cannot expect exactly where the final level of the crestable will be located. We cannot expect if there is a lot of inflammation. And also, if there's a lot of inflammation, it's unpredictable. Sometimes, even though we apply the implant, it increases the rate of the failure. So in the case, we are postponing the implant later. I mentioned the defect size and the primary stability of the implant and the presence of the inflammation. This is 3 factors we have to consider. Then the safe way is doing the implant later. I mean the early implant placement after healing, because most of the change of the extraction socket will happen during the first 3 months. So extractor tooth after 3 months, there will be, and placing implant will be more predictable. because we can exactly see where we have to locate the implant vertically, because after 3 months all the major change of the dimension of the extraction socket, dimension of the alveolar ridge already happened. So therefore we don't have to worry about the change of the ridge anymore. So it is a safe way. But mostly we can expect the location of the final location of the ridge, estimate not accurately, but most of the case we can expect in the fresh extraction socket, we can expect the final location of the ridge. Then we can consider immediate implant placement. Okay. The second question is, if primary stability is lower than expected, what is your backup protocol? I told you the immediate implant placement for the primary stability is really important, but only 3 steps. I told you the for lower anterior tooth area, 3 sequence, only 3 sequence. Once you finish the three different 3 sequences, there's no more chance for the changing the location, changing the axis, or changing the whatever. So if you have failed the primary stability, if you lose the primary stability on the posterior tooth area, there's one best way. You can increase the size of the implant. Let's say you are expecting placing 4.5 diameter implant and fail to get the primary stability, then you can place the 5.0 diameter implant, one size bigger implant. Most of the cases you can get the primary stability lower anterior tooth area. Let's say you fail to get the primary stability with the 3.5 diameter. Can you think you can place the 4.0 diameter implant on that specific area? It's not possible, because if you are placing the 4.0 diameter implant on the low anterior tooth area, it will be ugly. There's some part of the metal abutment and the implant will be exposed outside. It's not good choice. So anterior tooth area, the only way, if it's alveolar bone vertically, apex of the bone, apex of the root, if there's enough bone, safe area, we can place the longer implant. We can get more stability in the area we have under the apex of the root. If let's say there's enough bone, then we can, for getting the more primary stability, we can place the longer implant than we expected when we planned. So only way we can get primary stability for lower anterior tooth area is place the longer implant. Yeah, we have to do another step for making the more space for the apex lower than under the apex area. Then placing the longer implant is the only way. It's not the best way. It's the only way we can get the primary stability on the anterior tooth area. And yeah, that's the backup protocol. If we fail to get the primary stability, even though we place the implant, longer implant, and still we fail the implant, then it remove the implant and cover, fill the bone graft inside and the weight, and changing the protocol from the immediate implant to the delayed implant. Probably we can place the implant 3 months later. Okay, that's it. Could be the answer for the question. It was a good question, and I hopefully you can get a lot of lesson from my LiveSurgery. I'm not telling you that's the only way we can do the immediate implant placement and simultaneous bone graft. There's several different ways we can do you can apply the staged approach. You can open the flap and retro augmentation and in placing implant and the weight. There will be another possibility for the surgery. The reason why I introducing the technique, vestibular incision and the immediate placement, you can try you can think about the advantage or disadvantage of the vestibular incision. That is also two different protocol has a lot of scientific evidence. However, you can choose either one. However, you have to understand the vestibular incision has this kind of advantage and this kind of disadvantage. The opening the flap and doing the transmucosal GBR, this kind of it also have advantage and disadvantage. I'm just hopefully you got some lesson from my video. In the similar cases, probably you can choose your best one based on the literature and based on your preference. Okay, that's for my all about my presentation. Thank you for attention. Yeah, have a good one.